Please welcome Dr. Abonour.
All right. So my job is to get you awake so you can really pay attention to Dr. Richardson, because I think it's probably the most exciting talk of the day will be his take on how we treat relapse and bring you up to date on all these advances. One of the best in the business. So I'm glad to be setting the stage for you, Paul. So anyway, we're going to talk about bone disease supportive care in myeloma. So myeloma has been with us for a long time, actually. This is, I don't know, about 2,000 years old skull, and you can see these holes in the bones, these lytic lesions. And we just discovered more about the disease recently. And as you heard earlier, bone disease is about, 30% of you were diagnosed with bone disease. And a majority of patients will develop bone disease at some point during the course of the disease. And each patient presents differently, and we approach them differently. For example, this guy is 58-year-old who works in maintenance and at the local community center. Been having chronic back pain. Most people will have that back pain for a while. But then things start getting worse and had some muscle relaxant didn't work. So he had an X-ray of his back. And what you can see here is that there are these dark circles within the bone, the vertebrae. We call them these lytic lesions. And so what are these lytic lesions? Basically what happened is that for healthy bone, you have a balance between the cells that destroy bone, we call them osteoclasts, and the cells that build bone, we call them osteoblasts. And in myeloma, what you do have is that you have excessive bone destruction because you have tons of these nasty cells, osteoclasts, to your left. For remodeling the bone, what you need to do is you need to have a balance between these cells. And in the normal on the left, you can see that when you destroy bone, you sort of build bone. And it needs to look like a honeycomb. You know, that's the strong structures. And unfortunately, in myeloma, you just, weaken the bone, you get osteoporosis, and you just don't get a healthy bone. So really, treating the myeloma is very important to reestablish the balance, but also we need to address what happened at diagnosis. So, for example, when somebody has bone pain related to pathologic fracture, you can consider some radiation therapy. There are kyphoplasty and vertoplasty. We need to talk about that. Orthopedic surgery, pain medications, and then finally these two medications that are very important to treat bone disease, bisphosphonate and the rank ligand inhibitor. So radiation used to have a major role in the treatment of myeloma, especially bone disease. It does control the pain and accelerate healing. Now we have two procedures. One is the kyphoplasty and the vertebroplasty. We'll talk about them here in a minute. Surgery, I think, if you can get a surgery for, broken area, you should undergo that. That will stabilize the area and improve the pain control. And then obviously pain medications, balance between enough narcotics, not too much narcotics, local lidoderm creams or, non-steroidal anti-inflammatory drugs like ibuprofen. But, myeloma patients need to be careful with that because it can cause kidney damage or can also increase the risk of bleeding from ulcers. When you have a sort of broken vertebra, there are two ways you can address that by injecting sort of cement-like material to expand the vertebra, or you can put in a sort of what we call a kyphoplasty, where you get to expand the vertebra and then you put the cement in. So if you have really a significantly collapsed vertebra, you may need to do kyphoplasty. If you just have partially collapsed vertebra, maybe vertebroplasty will be enough. All right, so those are kyphoplasty and vertebroplasty can be very useful in controlling the pain in patients with myeloma. So this guy, really, what was his goal? I mean, I think he wants to go back to work. So obviously, he needs to be alert and, he was, willing to take some discomfort, but he wants to have mental clarity. So he, did not want to be on chronic narcotics, So that's okay. So each patient's level of tolerance of pain is different and need to be discussed with your physician. How about this lady? She's 63-year-old. She takes care of her mother, and she was diagnosed with multiple myeloma, and she was found to have a large lesion in her thigh bone. So you can see here in this, the arrow is pointing out to this, very nasty lesion in her femur. And what you see here is that the location of the lesion is very important because, you're seeing here thinning of the bone, putting this patient at risk a fracture. So location matter. If you have a lesion in the skull, that is not very important. But if you have it in a weight-bearing area, like in this patient, and looks like the bone is thinning, I think it's very important that we put a rod in to stabilize that bone before it's break. You can consider radiation therapy to that area, but it's so important to address impeding fractures quickly. So what are some of the imaging studies? You heard from Dr. Brian Dury this morning that skeletal survey used to be the way to diagnose these lytic lesion and pathologic fractures. Now we have several imaging studies that we can use. Whole body CT, I know that a couple of you had that already. Whole body MRI can also be very useful. And as you can see here in this picture to the right, a PET scan can be very useful because the PET scan can show you where in the bone there is a lesion and can show you if that lesion has active myeloma in it or not. Again, you see here in the pelvis, this yellow color should not be there. These are myeloma cells there. So I think we're moving beyond the skeletal survey to more sensitive assay to help us detect early myeloma, bone disease, and address that quickly. So the first drug we use to treat bone disease and myeloma, and we still use a lot of it, is zoledronic acid, or Zometa. And the way that works is that it does bind to the bone and inhibit the osteoclast from binding to the matrix and destroying bone. So you're still making a lot of osteoclast, but these osteoclasts are not binding to the bone and not breaking the bone. And so the initial trial that sort of proved that this is a very good treatment was a Myeloma UK trial number 9, where they compare Zometa to standard osteoporosis drug that we don't use in this country. And when you use Zometa, you have less bone disease than if you just use a typical osteoporosis drug. And actually, if you are a myeloma patient and you're getting treatment for myeloma, it's probably very important to consider zoledronic acid because even patient without a lesion had less complications, bone complications when they received Zometa than if they did receive different drugs. And this is what you can see here is the sort of reductions in skeletal-related events with this drug. So basically, we think that it's a very good drug. And the side effect, probably most of you have experienced some kind of flu-like symptoms the first couple days. There are several ways to deal with that, non-steroidal anti-inflammatory drugs, some steroids, Tylenol, and eventually will go away. Zoledronic acid can affect the kidney, so it's very important that we know the kidney functions before we give that drugs. So your doctor should be checking your creatinine and your calcium before they give you that drugs. And if your creatinine is going up, that's the kidney test. They need to adjust the dose and periodically pay attention to your sort of clearing of protein through the kidney. Sometimes that could be the first indication that this drug may be affecting the kidney. In about 3 to 4% of the patients, they may develop something called osteonecrosis of the jaw, which I told you earlier about is really sort of the jawbone become exposed, and then because of it becoming exposed, it get infected. In the old days, we really didn't know how to deal with it, and we send it to this guy in Miami, an oral surgeon, who will do tons of procedure, and really the best thing is to do less. Because when you start digging into the bone and the bone will get worse and it doesn't heal and you get more complication. So the best treatment for osteonecrosis of the jaw is to stop the Zometa, use an oral antibiotic if there's inflammation around that area, use a mouthwash, and I tell my patient I always look in their mouths to make sure they don't have any exposed bone, and if I see an O&J, I'll say, okay, we're gonna do these 3 things, and if you still have osteonecrosis in the jaw in 6 months, I'll buy you dinner, and luckily I have not bought any dinners yet. So it can go away but you have to be very careful. You just don't want to do too many procedures. If you're going to have a dental extraction, cleaning is fine, putting a root canal is fine, but dental extraction, any surgery on the jaw, you really need to stop the zoledronic acid, the Zometa, at least a month before you start, and don't restart it until that area heals. It's very, very important. You know, it's very useful drug, but we need to be very careful when we use it. But it's not good enough alone. I mean, I think, you know, every time we use these drugs, we need to make sure that we have adequate vitamin D store and calcium on board, and we need to exercise. We need to have weight-bearing exercise is very important. Walking is one of the best weight-bearing exercises that we have, and I think that's very important for healthy bone formations. The other drug we use for managing myeloma bone disease is this class of drugs called rank ligand inhibitor. Basically, what you're trying to do is make less osteoclast. Make less osteoclast. Zometa work on just preventing osteoclast from binding the bone. This drug, Xgeva or denosumab, is just making less osteoclast. So if you have less osteoclast, you will have less bone destruction. It's very important that when you're using Xgeva and you stop Xgeva, I don't know how many people in the room on it, what happens is that you may get actually flare. You may start making more osteoclast, and you may get some bone destruction. So some people may use Zometa for like a month or 2 to sort of counteract any new generation of new osteoclast, okay? So this is actually, not everybody knows that phenomena, the flare after you stop denosumab. But the reason we use this drug, because there was a clinical trial that tried to compare denosumab to zoledronic acid, and there was a lot of updates on that trial. But the question is that, which one is better? You know, denosumab is an easy drug because you give it underneath the skin. You don't have to worry about kidney functions, so that's why that drug was developed. And what it looks like in the primary endpoint analysis, there's actually bone destructions were identical. So the denosumab was not inferior to zoledronic acid, and there's a suggestion that may actually improve progression-free survival and maybe in some further analysis, overall survival. So maybe slightly better than zoledronic acid, and so it got approved finally in treating patients with multiple myeloma. In terms of you compare them head-to-head in terms of safety, obviously they both are well tolerated. Both of them can cause osteonecrosis at the same rate, but there are more renal issues related to zoledronic acid compared to denosumab. But they all can be given safely with close monitoring, all right? So these are the sort of safety of interest, you know, the renal issues that you don't see with denosumab, but you're gonna see some with zoledronic acid, and the osteonecrosis of the jaw was about the same, statistically was not different. So I guess the conclusion of that, you know, we have 2 drugs to use to treat bone disease, both effective, maybe one reduce improve overall survival compared to the others. The other thing is that don't forget that the drugs we use to treat myeloma can actually work on osteoclast and osteoblast. So for example, lenalidomide may inhibit the sort of degeneration of more osteoclast, and bortezomib may stimulate the generation of osteoblasts, the cells that build bone. So myeloma therapy itself and getting rid of myeloma is very important and can improve the outcome. So that's kind of summary for bone disease. So I'm going to touch briefly on several areas. One of them is infection. So I remember Bob Kyle, they're celebrating his 91st birthday today at Mayo Clinic, and Bob Kyle said, you know, you have fever because you have infection until proven otherwise. Myeloma patients do have increased tendency for infection because they have both antibody production deficiency and they have cellular immunity deficiency. So for example, now we're using a lot of drugs that can reduce your normal immunoglobulin. So if you check your IgG and you check the normal level, it's usually low in most myeloma patients. And during the winter months, they may have excessive episodes of pneumonia and bronchitis. If somebody gets a serious infections in the winter and they have low immunoglobulin, I think giving them intravenous immunoglobulin once a month is very useful. It can reduce the risk of needing to go back to the hospital to treat pneumonia and the like. Vaccination is very important. And after treatment, we need to make sure that we consider pneumococcal influenza and the new herpes zoster, not the old one, the new one because it's a killed vaccine. Now, prophylactic antibiotics, don't forget that you will need some prophylactic antibiotics, but the most important prophylactic antibiotics that don't ever forget to take is acyclovir to prevent the activation of herpes zoster because you don't want to get shingles. I don't know, anybody had shingles in the room? Oh my gosh, that's too many. How many have horrible pain because of that? Yeah. So the best treatment for herpetic neuropathy is not to get it. And the way not to get it is to be on acyclovir. And any dose of acyclovir better than nothing. So we used to say if you're on bortezomib or proteasome inhibitor, Velcade, you need to be on acyclovir. I think most of myeloma patients, when they're on therapy, we should be considering acyclovir, okay? So please remember that because you don't want to be spending the rest of life dealing with this post-herpetic neuralgia. The other thing is the hematologic complications. A lot of you I saw in the room getting treated for many, many years with many drugs, had a prior transplant, your bone marrow function is not going to be normal. So you're going to have low blood counts. You're going to have low white cells, low red blood cells, low platelet count. So it's very important that when we're treating a patient, if we need to make sure that they get the right treatment at the right time, we may need to use growth factor like Neupogen or erythropoietin. And the other thing is that, again, with anemia, it's one of the most under-evaluated laboratory finding in myeloma patients. Every time you have a patient with anemia, the question is why? The disease is under control. Myeloma is going away. They're still anemic. Are they vitamin B12 deficient? Is there iron deficiency somewhere? Is there B6 deficiency, folate deficiency? Is there the thyroid functions reduced? Is there low testosterone? We need to always investigate why our patient is anemic and address that. It's very, very, very important. How about GI symptoms? I mean, most of the drugs we use, they can cause either constipations or diarrhea, and I think it's very important that we have a healthy diet, probably high in fiber, and try to, eat stuff like yogurt and maybe consider probiotics, and stay very well hydrated. But we know, for example, if you have diarrhea related to Revlimid, there was a UK study that showed that cholestyramine can actually improve that. So when I have a patient on Revlimid and start developing diarrhea, I just start with once-a-day cholestyramine. Sometimes I go twice a day. It's not that pleasant to take, but I think diarrhea is not very pleasant to manage, And so I think we need to make sure we pay attention to that. And then neurologic complications. I think neuropathy is one of the most devastating and I think symptoms that you guys deal with. And I always say that prevention is the best treatment for neuropathy. Don't get neuropathy. Don't get bad neuropathy. Communicate with your doctor early on when you have sign of neuropathy. We have guidelines how to adjust the treatment, how to prevent you from getting horrible neuropathy, because the sooner you communicate with us, the more likely we're going to help you avoid debilitating neuropathy. There is a lot of things we use, sometimes minerals, calcium, magnesium, vitamin E, A, omega-3 fatty acid. All these things are very useful, and I think You know, do you still have that website?
Yep.
Yep. We do. So the Dana-Farber have a website that really goes on how to manage neuropathy and list all these medications. We use anticonvulsant. Oh my gosh, that's not conversant. Spell check didn't go well here. Maybe I used the same spell check the president used. Sorry. But anticonvulsant, I think they can be useful. An antidepressant can be very useful. So Lyrica, gabapentin, Cymbalta, such drugs can be very useful. But I have to say that really I have a hard time managing neuropathy. I think I really love to be able to prevent it. I think that's the most important thing. That's the honest questions, but you can try any of these things. So in summary, I think supportive care is an ongoing discussion with your health care team. It's very important. You can't stop talking about your symptoms, your quality of life, and this is bold, just like me. Walk away if no one asks you how do you feel when you go to a clinic. Walk away, find a clinic where they ask you how you feel. What's your performance status? What are you able to do? What's your life like? How is your GI tract? How is your sleep? How is your energy? Do you have any neuropathy? Do you have any pain? If nobody asks you these things, I think you're not getting the best care. Bone disease is a major complication, but we have many good options. We have 2 drugs we can use. Make sure you're taking enough calcium and vitamin D. Make sure you can walk. That's very important. Addressing fatigue, anemia, and GI symptoms and blood counts all can be managed with somebody who's willing to listen to you and investigate with you what's causing that. And I think neuropathy is a major complication, better to prevent than to treat. And with that, thank you.
All right, so thank you very much, Rafat, for that excellent overview about bone and other supportive care. So I think that we actually have a few questions.
Should you take Zometa if you don't have a bone issue?
Okay, I was going to bring that up with Rafat. So would you like to answer that question? If you've not had active bone problems, should you take Zometa?
So if you are a myeloma patient needing treatment, the data suggests that if you take Zometa, you're going to benefit from it. So even if you didn't present with bone disease, you can prevent bone disease. So I think most of us will do that.
You emphasized weight-bearing exercise and that walking was very good. What about running? Is that liable to damage, to do spinal damage, for example, because of the...
So you end up with these scooters.
Yeah, you can end up with scooters. This is from ultra marathon and marathons. No, I mean, I think, this is not a very easy question without knowing what your spine look like, what your x-ray look like. So each patient is different. I think, I have patients who run, but they don't have pathologic fracture in the spine. They don't have lesions in the spine. That's fine. But if, so I think somebody need to be very careful looking at your x-rays to tell you if you can run or not. But it's a good exercise, I mean, if you can do it. Yeah, I would agree.
All right.
They tried me on Xgeva. Isn't that what it's called?
Okay.
And I had a bad reaction from it.
Okay.
So can I take one of those other ones and not have a reaction?
That's a great question. I would agree
most likely,
100% that you should, because in my experience with Xgeva, it's been a great add-on, but I've had a number of patients, disproportionate to what we saw in the clinical trial, really run into issues with it. Typically, the hypocalcemia that we've seen with it has been much more sharp than we were expecting, again, from the trial experiences. So it's very important if you're on Xgeva to take calcium and vitamin D. I even had a patient of mine who got tetany because her calcium fell down so fast. So very important to be active about that.
So what kind of reaction did you have, though?
It looked like somebody beat me up and it got all bruised on my jaw.
Oh.
Mm-hmm.
Probably.
But it's very important that, when they give you anybody who's on Xgeva, is that that day, you know what your calcium is. So you don't want to give it to somebody with calcium of 8. I mean, that's too low. So that's one of the tests that we do. I mean, every time you get Exgiva that day, and somebody need to know your calcium before they inject you.
So that was a tetanic response.
Thank you.
Okay.
Thank you. Right back here, please.
Yes, I was on Zometa for 2 years, and I was taken off of it. And so I'm just curious, do they ever recommend, once you're off, can you ever go back on it, or that's it?
All right. It's a good question. If you go back on it.
I'd be happy to. Yes, in our program, we don't usually recommend that you stop unless there's an issue that means that it's a toxic or it's a less efficacious approach in your case. For example, if someone develops renal dysfunction on Zometa, we will often then recommend the switch to Exgiva with the cautions that we touched on with the other lady who asked the question before to make sure they tolerate it. There's a property of Zometa that's, I think, underappreciated, that it has an immune effect on what we call gamma delta T cells, which are the T cells that police the bone. And there's some evidence that that's important to the way it works. So it acts as an immune functioning drug as well. So there are advantages to Zometa in the longer term as a maintenance strategy that makes sense. Having said that, I particularly appreciated Rafat's comments about Exgiva because, as he pointed out so nicely, it does work in a different way. In any event, some form of treatment to support your bones makes sense. And I agree with Brian, especially if you have underlying bone disease, if at the time of your presentation or subsequently your myeloma has evidence of having attacked your bone.
So, so one thing is that if somebody, I agree with continuation of Zometa every 3 months, but at 2 years, if somebody did not have bone disease on presentation, do not have bone disease now, and their myeloma is in remission, I may tend to actually stop. One of the reasons is that, bisphosphonate do stay in the bone for a long time. I mean, they don't, if you don't have bone turnover, you're not making more, osteoclasts destroying more bones, they're sticking to the bone, they stay there. So what happened is that in few patients, what you get an imbalance between osteoclast and osteoblast, and you have tons of bone formation, but it's not countered by osteoclast. And what we're seeing is something called atypical fracture. So in the old days, we used to say, every time you have bone pain, you have myeloma. Now, if you are in remission, you're on bisphosphonate, and your myeloma is fine, and all of a sudden you have a femur pain, and you do simple X-ray, and you don't see a lesion or fracture, this is probably stress fracture from atypical fracture from being on bisphosphonate for a long time. So we always have to balance risk and benefit of everything we do and not overdo it. But I think I agree with Paul is that somebody who has bone disease, still have some residual myeloma, it makes sense to do it every 3 months after the 2 years.
Right.
Following your
yes.
point, always asking this question, the interest of diphosphonates was shown some years ago at a time where the treatments of myeloma were not as effective as they are now. Now that we achieve very good complete responses, including MRD negativity, do you think that the impact of diphosphonates will be the same?
Well, but I mean, the recent denosumab versus zoledronic acid is done in the area of the RVD. I think, I don't know what percentage had these good combinations. I think still, if you have bone disease, they may play a role. The question is, for how long and how do you do it, how you dose it. We may have to investigate that.
Yeah. No, the metaphor I use for my patients is, as you think of treatment, Jean-Luc, you sort of have your Army, your Navy, your Air Force, your Marines, and I think of the bisphosphonates as my Coast Guard. You need them there as well because they do contribute, but you're absolutely right, especially in a patient who might be at risk of, say, brittle bones or some other issue, then it may be appropriate to pull back.
I take up the point of Jean-Luc. I think that especially since we're treating myeloma a lot earlier, many patients don't have so much bone disease, and if you have dramatic early response, you mostly have patients who don't have any bone disease and are not likely to get bone disease anytime soon because we know the remissions are going to be lasting for a number of years. So I think we do need to look at it moving forward, the use of those agents. All right.
Okay, over here. Once you get the new shingles vaccine, is it still necessary to stay on the acyclovir?
All
I
right.
was hoping nobody will ask that question. I don't know, really. I mean, if somebody's still on therapy, or go back on therapy, do you wipe out any immunity? I just really don't like herpetic neuralgia, the nerve pain after herpes zoster. I'm so, because I'm underwhelmed. I mean, I use all the stuff I have. I send them to neurology. I send them to pain clinic, and they're still struggling. So I'm hesitant not to use acyclovir. And I told you, any dose is better than nothing. So if you take 400 a day, that's actually better than nothing.
Yeah, I agree, Rafat. I recommend both Shingrix plus the vaccine, because in fairness, there are days when you forget the acyclovir or the Valtrex or whichever is your preferred antiviral, and I think the Shingrix gives you that degree. But it's a very important principle that in our disease that the immune reconstitution that you get from a vaccine is not the same as in a normal host. And so for that reason, you can't expect it to give you the protection that it gives to a person who's not affected by myeloma. So I agree with you, Rafat. I think you double down, and then you have the reassurance that if you miss your pills or you travel and go on a vacation and forget your acyclovir for a few days, hopefully the Shingrix will give you some help.
So along the same line, just to broaden the discussion, one other thing that we've realized is that with daratumumab, it also attacks the immune system, and there can be a problem with reactivation of hepatitis virus. And so just to be sure, when you're going on to daratumumab, the new recommendation is that you do get screened to make sure if there's any indication of hepatitis virus, particularly hep B.
I wondered if you could comment on, and you may say, I was hoping nobody asked this question, but when we're on the subject of zoledronic acid, in the absence of bone, and I guess you're calling a bone disease, I was wondering in osteoporosis in somebody with smoldering myeloma, can somebody or one of you or all of you comment on how long one should stay on that? And is there a protective mechanism? I mean, I guess there would be because you're preventing the osteoclast from binding, but I wondered if you could comment with smoldering.
So this is, this is a very important question about the use of these agents like Zometa in patients with smoldering myeloma. And what's going on with the bones in patients with smoldering myeloma is another starting point.
Paul wants this.
Yeah, no, I think it's a super question, and thank you for asking it. In our practice, we believe that you should be proactive with osteopenia because you're absolutely right, the mechanism is there, but the data support it. There are trials where they looked at early use of bisphosphonates, and they showed a reduction in skeletal events if you did take it, but not if you didn't. The challenge was, did this translate into what we call clinical benefit, i.e. progression-free or overall survival? Well, I would argue from my perspective, if we prevent you having a bone event, that's surely a win. Interestingly, if you look at the Spanish trial, where they actually would not allow you to have bisphosphonates in that study, where you had Revlimid and just observation, the primary driver of events in the patients who did not get Revlimid were bone events. And unfortunately, that translated into a loss of survival benefit. So my view of that data, therefore, is that unless there's an indication why you shouldn't have a bone strengthener, it really makes sense to use it. Again, with the caveats that Rafat so nicely outlined, dental health, brittle bones, kidneys, and so forth. Great question. I would follow the same algorithm, which would be 2 years and then cut back. And honestly, then there's some patients after a year or so, and if their smoldering disease is very quiescent, I think one can be a little flexible because, again, it's a useful strategy.
But obviously, we need to distinguish between osteopenia and osteoporosis. If you have osteoporosis, you get treated forever, pretty much. I mean, unless bone density change. Yeah.
Yes.
Right, and there is osteoporosis or osteopenia, which is linked even with MGUS and smoldering myeloma, which might require regular treatment for that. In other words, we use the oral bisphosphonates for that versus the Zometa. Or you could use more of an osteoporosis schedule, which would be Zometa once a year, maybe, which could be considered.
Doctors?
Here, sir. Thank you.
In a patient who had been on Zometa for 3 years and was in remission, and now has a CT that shows active lytic lesions, is that an indication to restart the Zometa plus altering the chemotherapy?
That's a super question, and I'd love Rafat's view on this as well, and Jean-Luc's, but that's exactly the indication where I'd go back to monthly, and I've done that. Oh, absolutely, because intuitively it absolutely makes sense, because Rafat made a very good point that biochemically bisphosphonates are taken to cortical bone and deposited. But in terms of their function, as his slide showed so nicely, it's that effect on migration of the osteoclast, activation of the osteoclast that's important. So if the bisphosphonate's inert in the bone, it's not doing that. So it's kind of the journey from the bloodstream into the bone and across that surface that slows the osteoclast down. So therefore, going back to the more frequent bisphosphonate, if the bone becomes more active, is absolutely, in my view, reasonable.
Yeah.
How long would you continue the therapy?
Well, again, until you're under control again. So God willing, you get good treatment. You go back onto it monthly until your disease is under control. And then again, if you, God willing, go into complete remission, hopefully so, then you could then stretch it out again. And also, frankly, that might be the situation where if your kidneys squeaked a little bit because of other issues, that might be an indication to switch to denosumab.
All right.
I'm very confused.
Okay.
I do have bone lesions. I have never taken those drugs, and now I'm wondering whether I should try or move on to the next level of cement, or
No.
I don't know.
No. So are you getting treatment for myeloma? Yes. Okay. And never been offered any of these two drugs?
Well, right before I was diagnosed, I had serious dental issues, which I'm still struggling with for over 4 years.
Yeah.
So I think that was one of the reasons why they,
I think they probably did the right thing. If you're really having dental issues and you're going back to the oral surgeon and they're still working on your jaw, it's probably not wise to start these medications. But I'm hoping that in 4 years they should have fixed everything by now.
You would think.
Although I will say one thing, I completely agree with Rafat, have your teeth taken care of, but of all the 3 drugs that's least associated with osteonecrosis of the jaw, Zometa and Activism are the same, but Iridia is less. So if your bones became a problem for you, and especially if you're starting to get bone pain, and our dental service recommends Iridia as the safest bisphosphonate if you have dental issues, because they're very aware of the fact that worrying about ONJ is one thing, but allowing your bones to just get worse under your eyes is also not wise.
Okay, we have time for one more question.
Are there any drugs that would increase the osteoblasts?
Aha. Good question. So these are drugs that we're talking about, all of them inhibit the bone destruction, but how about improving the bone healing?
Yeah, so we actually worked with, there's a drug called, that doesn't have really a name, so ACE-111, and basically that can actually stimulate osteoblast. And so I work with a guy at our institution, his name is David Rudman. He's nationally, internationally, known for studying bone disease. And so he has 2 molecules that, interested in. One of them was this ACE-111, I think. And basically, the problem with that drug is that it actually can stimulate red blood cell production. And the company that had this drug, I'm not going to say their name because they're probably here, did not want to deal with that because they were worried that we're going to raise the hemoglobin too high, the patient will start having stroke. And it'll probably never happen in myeloma patients, because they are on drugs that actually can lower the hemoglobin. So unfortunately, that drug is not going to see the light of the day. So there's another drug with another company that can stimulate osteoblast, and I think they are waiting to get that drug approved in osteoporosis first, and once it's approved in osteoporosis, we will start studying in myeloma.
Yeah,
That's good.
And Rafat touched on another key point, that one of the most osteoblast-inducing drugs are, of course, the proteasome inhibitors. So bortezomib, carfilzomib, and ixazomib all have a favorable effect on the osteoblasts. So they're not as strong as the drugs that Rafat alluded to, but they're part of the armamentarium.
What about growth hormone or parathyroid hormone?
Yeah, I mean, I think the problem with these drugs is that there's a risk of stimulating other cancer, including bone cancer, and none of the companies are willing to study those right now.
Yeah, that's a problem.
Yeah, no, I
Okay,
agree.
I think that's good. So thank you all for your interest in the bone disease.